So, Hallie, let's talk about the maxillary premolar tooth for a moment and how it may be similar but yet different than what we just discussed.
Yeah. Maxillary premolar tooth, a tooth that commonly requires endodontic therapy, unfortunately. There's maxillary first and second premolar, and they're different in terms of configuration and what you expect in terms of the number of canals and the difficulty level that you may face. Now, the maxillary second premolar, I probably think is one of the easiest teeth in the mouth to do. Most of the time you end up having one canal in there, but sometimes you end up having two, and rarely you may have three or all kinds of different branching that's going on there. So you need to be aware of that. On maxillary first premolar, on the other hand, pretty much always you should expect to have two canals. If you don't find two canals in your maxillary first premolar, then you better take a bunch of angulated x-rays to make sure that you only have one, because it may mean that you missed one, and that's part of the problem with those cases. But the maxillary premolars, the axis, again, follows the same general outline as we discussed conceptually of the outside shape of the tooth. However, on the maxillary first, you basically have a fairly oval shape, and you make sure on your maxillary premolars that you don't, as you mentioned, Dennis, on the anterior teeth, you don't just make a little round hole in the middle. This one definitely has to be oval, because you have, as I mentioned, over 90% of the times you will have two canals in there, 95% of the time. So there's one canal here and one canal here, and you're not going to find it with a round axis. You have to have an oval axis preparation. So your axis preparation will allow you then to get into the pulp space that's basically in this area. But maxillary premolars, as well as mandibular premolars, oftentimes have an angulation. So your axis preparation here, by the way, will allow you to get into the pulp space that is basically out in here. So you're trying to unroof this and then find both the buccal and the lingual canals. Oftentimes, the mistakes that occur with these have to do with a lack of understanding of the potential angulation that is present. By putting a rubber dam directly on the tooth, having a bridge or a crown on the tooth that misaligns the coronal part to the root part, and people end up perforating either mesially or distally. So those are the parts that you want to avoid by getting the misalignments. There. Again, I use the same 1557 or 1558, depending on the occlusal table that I have here it's with, and get the axis going as straight as possible. Make sure if you take an x-ray in advance, make a little measurement as to how far you have to go before you get to this thing. And oftentimes, there's a little trick I can tell you. If you have calcifications, let's say this root starts here, and you've been drilling and you just can't find a canal. The trick is on the ESX obturation system, the sealer uses bioceramics called BC Sealer. BC Sealer is very easily kind of cleaned out of the canal using the ultrasonic, but it's also very radio opaque. So a nice little trick that I have found is let's say you've made your axis preparation, but you don't know where you are. You take the BC Sealer and you inject BC Sealer into your axis preparation. So you basically end up getting a full radio opaque impression of your axis preparation. Then you expose a bite wing x-ray, and you will have a very nice impression that you've taken, and you will be able to use that just to realign yourself depending on how far you're going. You may say, oh, I'm in the right place, but I'm not deep enough. I need to go another 2 millimeters. Then you do that. So these are all little tips that you could use to improve your access using this material.
Ali, more times than not, I've seen when this is done, exactly what you're doing, that some of the BC Sealer will actually find its way into the canal.
That's happened to me too. You're absolutely right.
And that's great, because then you actually say, oh, you know what? I'm too deep. I can see that it's up on the lateral side.
Absolutely. So also central incisors, these kinds of teeth that really get the calcify pretty much up on top. Right. You may go in, you're going in this direction.
That's right.
And then you inject the BC Sealer and you're like, your little squiggly comes out this side. You're like, oh, wait a minute, that was there. So those are cases, unfortunately, you probably will need a microscope then to really see and find. But just a little tip to keep in mind.
So how about the lower premolars?
Lower premolars, either the easiest teeth in the mouth or the hardest. I can tell you, Dennis, I'm sure you agree with this.
Biologically, clearly one of the hardest. Because
Absolutely.
Mental foramen.
You got the mental foramen very close to this area. Any kind of an error would cost you and your patient a loss. So you need to be really on your toes the whole time. Same thing with the mandibular first and second, because every patient obviously is different. But the mandibular first has the most amount of anomalies in there. Mandibular second also has a lot of anomalies, not to kind of play that lightly. But this is a case in which you end up having all those type 4 wine classification type 4 canals, which is, you have one canal that comes down and then suddenly disappears on the x-ray. And that is called a fast break. When a defined canal disappears on the x-ray, it suddenly becomes like that. If you're a general dentist, refer that patient out immediately. Do not attempt to do a case like that yourself, because these are the cases where they blow up on you. You will need a microscope. You need a lot of expertise to manage to get into this so-called hook that is occurring here to clean, disinfect properly, and to obturate it. So you need to expect that. But in terms of their access preparation, the access preparation is the same way, basically an oval type of a preparation. But it's not quite as oval as this one. It could be a little bit less oval. Actually, I'm sorry, I should be doing it on the occlusal table here. This is the lingual aspect of it, if I were, and this is the side view. And in the side view, your axis preparation would basically be like this. And you're going straight, and then you got to adjust the course.
You reorient. Right.
This is the guy where people go straight through. Buccal perforation, the most common kind of an error you see on the mandibular premolars, is because of this orientation of the crown on the root. You want to go halfway in and then reorient moving down to account for the roots. And this is the guy also where you get 2 or even 3 trifidity going on at the end of the roots. Very difficult cases that I'd like to refer to you, Dennis. So you will see that in cases like that, just like the premolar, finding in the oval shape the lingual canal and then pre-curving your file, putting a little bit of an J-hook on it, try to walk it down. Let's say this bifurcation is a little further up, like this. Then you put a J-hook on your file again, and you walk it down lingually. Here again, just like the incisors as we talked about on the lower anteriors, you would like to use your DG16 for Explorer, but primarily for ultrasonics, you could use your E14 D-tip in order to get a little bit of enlargement in a conservative way towards the lingual, so you can expose that potentially hidden lingual root in order to be able to access it.
Most common error, I think, of all these things that you're talking about, is not extending this preparation far enough buccal lingually.
Yeah.
Going in thinking that you're going to use a minimal preparation, but you wind up missing a canal.
Yeah.
I've seen that hundreds of times.
Yeah, you don't want to miss the forest for the trees. You got to make sure that you are getting all, just not get so focused on making the smallest possible access,
right,
and in the process miss important canals that are present.
Yeah.
And that's why these teeth are always so much more difficult to treat, especially the mandibular premolars. And those are the cases that if you need to really refer to your endodontist.
One of the most important aspects of all of this is those 3 x-rays you talked about, and that angled x-ray on these particular teeth are so important in picking these problems up with multiple splits and bifurcations and so forth.
Yeah.
So some of your pre-access concepts are really important to verify.
Information. It's all about information.
It's all about information.
You don't want to start a tooth that you're not going to be able to finish. Your endodontist should be doing those cases because the first person who gets into the tooth has the best chance of negotiating getting down to the apex. You don't want to hand over a tooth that is very difficult to handle to them. All right, so let's come back and talk about the molars, the bread and butter of endodontics.
Okay.
All right.